Can I start? This is a very basic presentation on the interpretation of the macular OCT. So OCT is an imaging tool everyone knows, and it gives the cross-sectional images of the human retina. And this is the most commonly used machine, that is Series 500. And these are the various layers which we see on the OCT. And previously we used to see only under the microscope. Now with the help of OCT, we are seeing all the layers in vivo. So it was started in 1991, and in 2007, spectral domain OCT came into picture. And it's a non-contact, non-invasive imaging technique used to obtain high-resolution cross-sectional images of the retina. And it gives the qualitative analysis and quantitative analysis, that is the retinal thickness and the volume of the nerve fiber layer thickness. So these are the various scanning protocols, line scan and the macular scan. The various line scans are the single line scan, HD line, HD register, and the HD one line scans. And macular cube scan, most commonly we use it 128 into 512 because it has a better resolution than the 200 into 200. Normal macular layer, which are more important, are the vitreoretinal interface, inner retina, outer retina, choroid, and the sclera. So vitreoretinal interface, we'll see vitreous as a hyporeflective space, that is black, and premacular bursa, that is hyporeflective space in front of the macula. And hyperreflective continuous line is seen as a posterior hyaloid. In our retina, we see hypo and hyporefractive bands, and the layers which are axons perpendicular to the light or contain synapses appear hyperreflective, and the layers which only contain nucleus appear hyporeflective. Outer retina, the most important is RPE Brooks membrane complex and ellipsoid zone. So directly coming to the macular cube, this is the most common picture which we see in day-to-day OPD. And the first is the fundus image showing ILM to RPE retinal thickness map overlay. And the second is the slice navigator. Then third is the ETDRS grid retinal thickness values from ILM to RPE as compared to the normative data in 9 sectors. Then fourth is the OCT fundus image. Then the various are the fovea finder, horizontal crosshair line, and the vertical crosshair line. And the 11th one is the macular parameters compared to the normative data. So these are the 5-line raster scan. Directly coming to the common retinal conditions which we see, hyperreflective and hyporeflective. Hyperreflective, most commonly which we see are the drusen's, CNVM, hard exudates, hemorrhage, ERM, and hyporeflective are the intraretinal fluid and subretinal fluid. So the most important is to identify ellipsoid zone and RPE Brooks membrane. So we have to identify this. These are the most common condition which we see in day-to-day OPD. So these are the common diagnoses which we see. Like this is the first one is a compact. All the retinal layers are squished into one, and this is a normal OCT scan. And this is the intraretinal fluid, speckled in appearance, mainly seen in DME. And this is diffuse outer, which is seen in most of the time, vascular occlusions, empty spaces we see in the post-op CME, and the subretinal hyperreflective membrane or material, and subretinal fluid, which is seen in inflammatory CNVM, and PED along with SRF and IRF is seen in wet AMD. So before we get into all this, we need to identify RPE and ellipsoid zone. So in this picture, as we can see, the RPE is seen by the red arrows, and the hyporeflective area between the two is the SRF, which most commonly we see in the CSCR. Now, in this case, in this we identify the RPE and ellipsoid zone. Hyporeflective space indicated by the star is SRF, and PED is also seen is any elevation in the RPE. And subretinal fluid and PED. So again, this is more important because we'll be able to make out by seeing the OCT only whether it is an active CNVM or it is an inactive CNVM. Subretinal, if it is amorphous, we cannot make out, and then it is a sign of active CNVM. And if it is a consolidated, it is most of the time it is a sign of inactive CNVM. So, and outer retinal tubulations are, these are the signs of chronicity of the disease. And this here I'm normally seen as a hyperreflective band attached to the inner retina. This is the most commonly seen in full thickness macular hole. So this is OCT of one of my patients of the full thickness macular hole, and this was one of my patient who had a vascular occlusion, and post anti-VEGF, she improved with one injection, and now she is following up. And this was again DME, and post ILIA it improved drastically. And this was a case of CSCR. Thank you.
Yeah, very nicely presented. It was such a vast topic, so it was very difficult for you to cover all. And just one point I want to highlight to you is that every hyperreflective space that you see in the outer retina is usually not subretinal fluid. There could be pseudo SRFs also. So these are just common things that you have presented. There are patients with vitaliform diseases and things like that, which are not really even non-exudative pigment epithelial detachment. So you really don't need to think of them as a fluid. It's never the actual fluid. And one more point is that in your practice, don't look at the printed copies that the patients bring to you. Always go back to your machines and look the live scans, because so many times you will miss a laminar macular hole to a macular edema and vice versa. Yeah. Thank you.
Actually, this is the point I too was about to tell, that especially for the delegates, that usually what happens is that anterior segment colleagues who have OCTs, they just ask the technician, iska OCT kar lao. And then a very badly printed report is sent to a retina specialist, and when the retina specialist asks the patient to get a new OCT done, the patient thinks that we are greedy and we want to make some money out of it. But kindly look into a machine. One line may not be sufficient, and teach your technician. Once you get up from your chair, go to your OCT room, there are 3 benefits. Number 1, your technician will learn where to do the OCT, where the pathology is. Second, you will get a better pictures for your patient. Your patient will benefit. And third, it will be beneficial for you, because सारा दिन का जो chair time है वो कम हो जाएगा. You will be walking, so your belly पे fat है वो कम आएगा.